Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular session, I'll be discussing the multiple choice questions on the topic of the bronchogenic carcinoma. So the first question is, right, it's an image based question. We have a 65-year-old uranium miner presents with muscle cramps, early morning headache, chest x-ray and non-contrast CT scan is being done and which is being shown here. What exactly is the answer? The options are small cell carcinoma of the lung, brain metastasis. Second option, non-small cell carcinoma of the lung, brain metastasis. Third option, pleural and intracranial calcification. Fourth option, glioblastoma multiforme, extracranial spread. So what is that you are able to make out in this particular patient is, the individual is a uranium miner. Now, in case of the uranium miners, what is these particular patients at risk of? Uranium miners, like they are at risk of exposure to the radon gas. Right? The uranium miners, they are at risk of exposure to the radon gas. And this radon gas, it is an inert gas. Right, this radon gas, it is an inert gas that is the product of a uranium decay. And in case of the uranium miners, where there is exposure to the radon gas, the type of bronchogenic carcinoma most commonly observed is the small cell carcinoma of the lung. Now, what is this chest x-ray showing? The chest x-ray, you can make out that there is a lesion in the right paracardiac area. You can see that white color arrow also. So in the right paracardiac area, there is a lesion. That means there is some mass, right? And within the brain, if you observe that there is the lesions within the brain as well. So you can make out this opacity is within the brain. So now the individual is having the occupational history of the uranium miners, where there is exposure to the radon gas. There is a mass in the right paracardiac area, and you also are having opacity within the brain CT. So what is all this suggestive of? This is all suggestive of the bronchogenic carcinoma, right? Because the very important history is exposure to the radon gas, where because the individual is a uranium miner. And parallel to that, there is a mass in the right paracardiac area that might have metastasized to the brain. Now, which type of bronchogenic carcinoma is the most common bronchogenic carcinoma which have the higher tendency of metastasis? The type of bronchogenic carcinoma which has the higher tendency of metastasis is the small cell carcinoma of the lung, which is a highly aggressive tumor, right? Which is a highly aggressive tumor. Now, this small cell carcinoma of the lung, right? This can cause the development of the muscle cramps. Now, you need to know how it will cause the muscle cramps. This small cell carcinoma of the lung, it has the ectopic secretion of the ACTH, right? So this ectopic produced ACTH, which will increase the steroid production. This steroid, which is coming from the ectopic source in excess quantity, it will activate the ENaC channels, that is epithelial sodium channels, which are present in the principal cells of the distal convoluted tubule. Now, once these ENaC channels are activated, there will be sodium and water retention, potassium will be excreted, so thereby there will be hypokalemia, and H+7 also will be excreted, and that will result in the hypokalemic metabolic alkalosis. Right, hypokalemic metabolic alkalosis. Okay. Now, it is because of this hypokalemia, these patients will develop the muscle cramps. And what could be the reason for this early morning headache is that is because of the brain metastasis. There are presence of mets within the brain, and that could contribute to the development of the headache. And what about non-small cell lung carcinoma? Doesn't it cause the brain metastasis? It can. What are the examples of non-small cell lung carcinoma? Large cell carcinoma, adenocarcinoma, and squamous cell carcinoma, right? But rather than this non-small cell carcinoma, the one which is highly aggressive, which is more common in uranium miners, which has the higher tendency of metastasis to the brain, is the small cell carcinoma of the lung. So that is the reason why the answer is A. Now, this small cell carcinoma of the lung, it is having the ectopic source of the ACTH, right? And it is also the ectopic source for many other hormones. There will be release of the antidiuretic hormone, and that will result in the SAIDH, syndrome of inappropriate antidiuretic hormone. And there will be also release of the atrial natriuretic peptide, right? And there will be also release of the calcitonin. Okay, and yeah, these are all the various hormones which are being produced from small cell carcinoma of the lung. But because of the increased production of the ACTH, that will result in the hypokalemic metabolic alkalosis. So the answer in this question is the first option, right? Now coming to the next question. Most common bronchogenic carcinoma is small cell carcinoma of the lung, squamous cell carcinoma of the lung, mixed cell carcinoma, and then the adenocarcinoma. So the most common type of bronchogenic carcinoma, it is the adenocarcinoma. If specifically a particular country is not given, then you just go with the adenocarcinoma. But if the question is asked, what is the most common type of bronchogenic carcinoma in India? In India, the most common type of bronchogenic carcinoma will be squamous cell carcinoma. Whereas all over the world, right, all over the world, the most common type of bronchogenic carcinoma is the adenocarcinoma. So adenocarcinoma, as I have discussed in the theory part of it, so it is the one which is commonly observed in non-smokers, right? And this adenocarcinoma, it is a peripheral carcinoma. And this adenocarcinoma, this is more common in females rather than males. And it is also the one which is observed in young individuals. And this adenocarcinoma is associated with one of the very important syndrome that is called as the Pancoast syndrome. Right? Pancoast syndrome. And the type of bronchogenic carcinoma which has the higher tendency of metastasis to the opposite lung will be also even adenocarcinoma. And these patients with adenocarcinoma, they have the higher tendency of development of the pleural effusion as well. And what type of pleural effusion do you observe in case of the adenocarcinoma is exudative type of pleural effusion will be present. Okay, so these are some of the important points on the adenocarcinoma, and which is the most common type of bronchogenic carcinoma. All right, next question. All of the following statements about small cell carcinoma are true except it's the commonest malignancy of the lung, associated with paraneoplastic syndrome, causes SVC obstruction, chemosensitive, and commonly metastasize to the brain. Okay, so which is the incorrect statement? The incorrect statement is the commonest malignancy of the lung. It is what is the incorrect statement here. See, actually what is the commonest malignancy of the lung? The commonest malignancy of the lung is the adenocarcinoma. All right. And it is associated with paraneoplastic syndrome is true. Just now we have discussed small cell carcinoma. See, another name for small cell carcinoma, it is also called as the 𝗏𝐻 cell carcinoma. So this small cell carcinoma or the 𝗏𝐻 cell carcinoma, it's a paraneoplastic syndrome for the excessive production of ACTH, for the excessive production of antidiuretic hormone, for the excessive production of atrial natriuretic peptide, and for the excessive production of calcitonin as well. Okay. Next, now it can cause the SVC obstruction. That is completely true. Small cell carcinoma will cause the compression of the superior vena cava. Now, because of the compression of the superior vena cava, what will happen is the venous drainage from the face and venous drainage from the upper limb will not enter into the right atrium. Okay, so there will be decreased venous drainage. Right, there will be decreased venous drainage from right, there is decreased venous drainage from the upper half of the body, right? And these patients with small cell carcinoma, if you see, the treatment is mainly chemotherapy because it is a highly aggressive tumor. It has the higher tendency of metastasis. So that is the reason why this particular tumor, that is your small cell carcinoma, please remember that you have to give chemotherapy only. You cannot do surgery because it has higher tendency of metastasis to the different areas. Next, commonly metastasized to the brain, that is also a true statement. All right. So So the incorrect statement here is commonest malignancy of the lung is an incorrect statement. Next question. Yeah, in a chronic smoker, a highly malignant, aggressive and metastatic lung carcinoma is. The options are squamous cell carcinoma of the lung, small cell carcinoma of the lung, adenocarcinoma, and then large cell carcinoma. So the question is highly malignant, aggressive and metastatic lung carcinoma. So that will be small cell carcinoma. So small cell carcinoma, it is the one which is highly aggressive and it is the one which has the poor prognosis as well. And both of these, that is small cell carcinoma and as well as squamous cell carcinoma, both of them, they are associated with the cavity formation. And electrolyte abnormalities in small cell carcinoma, just now I have discussed, it is associated with hypokalemic metabolic alkalosis, okay? And it is a highly aggressive tumor, right? And among all these, the one with good prognosis is the squamous cell carcinoma. Squamous cell carcinoma, it has the good prognosis. And you can give chemotherapy and it can be aptly treated. So that is about your squamous cell carcinoma. Next question. Type of lung carcinoma producing superior vena cava syndrome, squamous cell carcinoma, adenocarcinoma, then small cell carcinoma and anaplastic carcinoma. So the type of lung carcinoma which will be producing SVC syndrome is small cell carcinoma, just now we have discussed. So because of the compression of the superior vena cava, the venous drainage from upper half of the body to the right atrium will be reduced. So in case of SVC syndrome, what will be the clinical feature is, you will notice that there is swelling of the face, swelling of the neck and swelling of the upper limbs. And these patients, they will also have a headache and they also have conjunctival edema. Right, they will have conjunctival edema. So these are the features of SVC syndrome. Whereas you take in case of the adenocarcinoma. In adenocarcinoma, the syndrome which is more common is the Pancoast syndrome. Okay, so what is this Pancoast syndrome? Pancoast syndrome, it is a syndrome that occurs for the tumors which are growing at the apex of the lung. Right, so your adenocarcinoma is a peripheral carcinoma. So the tumor which is growing at the apex can cause the compression of cervical spinal nerve C8, T1 and as well as T2. And there will be also compression of cervical sympathetic chain. Right, there will be also compression of cervical sympathetic chain, right? And because of the compression on C8, T1 and T2, the individual will have pain in the neck, right? And that will be radiating to the arms, right? The individual will be having pain in the neck and that will be radiating to the arms. And because of the compression to the cervical sympathetic chain, these patients with Pancoast, secondary to your adenocarcinoma, they develop the Horner syndrome, right? And what are the components of the Horners? That is ptosis, meiosis, enophthalmosis, loss of ciliospinal reflex and anhidrosis, where there is absence of sweating. So that is about the features of the Horner syndrome, right? And the next important finding that you will have in case of the Pancoast is there will be erosion of first and second rib, right? But most commonly it is the erosion of the first rib, then followed by that the erosion of the second rib. Okay, so that is what is the feature of the Pancoast that you see in adenocarcinoma. But SVC syndrome is observed in patients with the small cell carcinoma of the lung. All right, next question. Clubbing is the least common feature in squamous cell carcinoma of the lung, adenocarcinoma, small cell carcinoma and mesothelioma. So let me tell you, almost all the forms of this bronchogenic carcinoma, they are associated with clubbing. But clubbing, it is least common in patients with the small cell carcinoma of the lung. What could be the reason? The reason is that the pathophysiology in small cell carcinoma is slightly different compared to that of the other forms of bronchogenic carcinoma. And this small cell carcinoma, it is a highly aggressive tumor. Right, it is a highly aggressive tumor. So this small cell carcinoma, which is a highly aggressive tumor, by the time the clubbing has occurred, these patients will have the early presentation. Right, so it is not that in small cell carcinoma you don't have clubbing. Clubbing will be there, but by the time the patient presents with the clinical manifestation, clubbing might have not yet developed, but later there will be development of clubbing. Whereas in squamous cell carcinoma, adenocarcinoma, where the presentation is slightly late, by the time the presentation of the patient is there, the individual will also develop clubbing. Okay, and even mesothelioma, it's a tumor which is originating from pleura. Even these patients with mesothelioma also have the clubbing. Right, so small cell carcinoma, which is a highly aggressive tumor, these patients, they have the clubbing, but it is least common. By the time the patient presents with the clinical manifestation, clubbing might have not yet developed. Okay, so the answer is small cell carcinoma of the lung. But as such, if you take the respiratory causes for clubbing, this is one of the very, very important question. The respiratory causes for clubbing will be lung abscess, right? And the respiratory causes for clubbing will be empyema, right? And respiratory causes for clubbing will be necrotizing pneumonia, right? And respiratory causes for clubbing will be bronchogenic carcinoma, as we have discussed, then interstitial lung disease, then cystic fibrosis. So these are all the respiratory causes for the development of the bronchogenic carcinoma. All right, next question. Now, a patient presents with secondaries to the adrenals. The most common site of primary is lung, kidney, breast, and then stomach. Now, the patient having the metastasis to the adrenal gland, what is that you need to suspect as the primary is the lung. Now, that is your bronchogenic carcinoma. Now, at the same time, you need to be aware of what type of bronchogenic carcinoma will have the higher tendency of metastasis to the adrenals. That is mainly the small cell carcinoma of the lung. Right, that is mainly small cell carcinoma of the lung. So from bronchogenic carcinoma, the most common organ where the metastasis will go is to the adrenal gland, right? So that will be like most common endocrine organ. What I mean to say is the most common endocrine organ where the metastasis will reach, that will be to the adrenal gland. All right, and then see, whereas if the question is asked what is the most common organ where the metastasis will go from the bronchogenic carcinoma, will be the liver. Right, most common organ from where most common organ to where the metastasis will go from the bronchogenic carcinoma will be the liver, but most common endocrine organ will be to the adrenal gland. All right, so the answer here is the lung. Right, next question. We have a 40-year male patient presenting with polyuria, pain abdomen, nausea, vomiting, altered sensorium, was found to be having bronchogenic carcinoma. What do you think is the electrolyte abnormality seen in him? The options are the hypokalemia, hyperkalemia, hypocalcemia, and then the hypercalcemia. Now, if you take the bronchogenic carcinomas causing electrolyte abnormality, you have two important bronchogenic carcinomas, that is number one, small cell carcinoma, and then squamous cell carcinoma. Now, what are the types of, or what are the electrolyte abnormalities that you will have in small cell, and what are the electrolyte abnormality that you will have in squamous cell? Let me tell you. You take in case of small cell carcinoma, these patients, they are associated with increased production of the ACTH, that is adrenocorticotrophic hormone. And this increased production of the ACTH, it is associated with increased steroid synthesis, and this increased steroid will cause the activation of the epithelial sodium channels, and this activated epithelial sodium channels will result in sodium and water retention and will cause hypokalemia and will cause hypokalemic metabolic alkalosis. Okay, so one of the very important electrolyte abnormality is the hypokalemic metabolic alkalosis. All right, that is one thing. And second important is the small cell carcinoma is also associated with the release of the atrial natriuretic peptide. And small cell carcinoma is also associated with the release of the antidiuretic hormone. So there is excessive production of antidiuretic hormone that can make the individual to develop the SAIDH. Right, that is syndrome of inappropriate antidiuretic hormone, right? So because of these two electrolyte abnormality, release of atrial natriuretic peptide and release of the ADH, antidiuretic hormone, that is SAIDH, both of these hormonal production will make the individual to develop hyponatremia. Okay, now you take in hypokalemia or in case of hyponatremia, do you have the set of clinical manifestations which is given in the patient, right? Polyuria, pain abdomen. See, altered sensorium can be explained by your hyponatremia, but other features like pain abdomen, nausea, vomiting, that cannot be explained based on your hyponatremia. So your hyponatremia is ruled out. Then what about hypokalemia? In case of hypokalemia, like why the patient should be in a state of altered sensorium? Usually patients with hypokalemia, they don't present with altered sensorium. They present with muscle cramps. They present with polyuria, right? And they present with constipation. That will be the presentation in hypokalemia. But altered sensorium cannot be explained based on your hypokalemia also. So your hypokalemia is also ruled out. Now you take squamous cell carcinoma. Squamous cell carcinoma, what is the electrolyte abnormality associated is squamous cell carcinoma, it acts as an ectopic source for the parathormone. So parathormone, what it will do to the calcium levels? Parathormone, it will increase the calcium levels. Right? Parathormone will increase the calcium levels. Okay. So when parathormone is increasing the calcium levels, the individual will land up in what is called the hypercalcemia. Hypercalcemia, you will have all these clinical manifestations. Why there should be polyuria in patients with hypercalcemia? In patients with hypercalcemia, there is development of nephrogenic diabetes insipidus, right? So in response to your nephrogenic diabetes insipidus, these patients can have polyuria and as well as the polydipsia, okay? So polyuria can be explained based on nephrogenic diabetes insipidus. Now, why there is pain abdomen in patients with hypercalcemia? So whenever there is hypercalcemia, the calcium will come and accumulate within the sphincters of the GIT. Will accumulate within the sphincters of the GIT. So when the calcium accumulates within the sphincters of the GIT, there will be contraction of the gastrointestinal sphincters. The gastrointestinal motility is reduced. So thereby the individual can have constipation and pain abdomen can be explained. So forward movement of the food is not occurring. So subsequently these patients can have nausea and as well as vomiting. Then why is that there will be altered sensorium? These patients with hypercalcemia, they develop psychosis. Now, why do you think that there is psychosis in these individuals? See, the normal calcium levels, they are 9 to 11 milligrams per deciliter, or 9 to 11 milligrams percentage will be the normal calcium levels. But when the calcium levels have been elevated up to 12 milligrams percentage or 13 milligrams percentage, the calcium will cross the blood-brain barrier and calcium will accumulate in the brain. So once the calcium accumulates in the brain, that will result in the development of the altered sensorium or the psychosis. So the answer here is the hypercalcemia. The answer here is the hypercalcemia is what is observed, and it is secondary to squamous cell carcinoma. And one more important electrolyte abnormality that can be seen in small cell carcinoma is the hypocalcemia. Right, hypocalcemia. Why there is hypocalcemia in small cell carcinoma is because small cell carcinoma is also an ectopic source for calcitonin production, and this calcitonin can cause decrease in calcium, right? So with small cell carcinoma, the electrolyte abnormalities are hypocalcemia, hypokalemia, metabolic alkalosis, and then hyponatremia. Whereas in squamous cell carcinoma, the electrolyte abnormality that you will have is the hypercalcemia. All right. So the answer in this question is the hypercalcemia. All right. Next. A 60-year-old male presented to the emergency with breathlessness, facial swelling, dilated veins on the chest wall. What do you think is the probable diagnosis? Thymoma, lung cancer, Hodgkin's lymphoma, superior vena cava obstruction. So the patient is having facial swelling and there is like dilated veins on the chest wall. What does it tells you? It is suggestive of the superior vena cava obstruction. And this superior vena cava obstruction can occur secondary to small cell carcinoma of the lung. That is what we were discussing even in the previous questions also. So once there is SVC obstruction, the venous drainage from upper half of the body will be reduced and that will result in the facial swelling, and there will be also dilated veins over the surface of the chest wall. Alright, next question. All are the cavitating lesions in the lung except. The options are Kaplan syndrome, hamartoma, vaginous granulomatosis, squamous cell carcinoma of the lung. So which among the following is not the cavitating lesion? Right? The one which is not the cavitating lesion is the hamartoma. So what exactly is the hamartoma? Hamartoma, it is a benign tumor. Right? It is a benign tumor of the lung. It is a benign tumor of the breast. And it's a benign tumor of the skin. And in patients with hamartomas, right, in patients with hamartomas, there is no cavity formation. Right, there is no cavity formation in cases of the hamartomas. Alright, whereas Kaplan syndrome, what is this Kaplan syndrome? Kaplan syndrome, it is a disorder where there is rheumatoid arthritis plus 𝐒𝐻𝐼𝐴 pneumoconiosis. Right, 𝐒𝐻𝐼𝐴 pneumoconiosis. So 𝐒𝐻𝐼𝐴 pneumoconiosis is that where you have the cavity formation within the lung. Right, multiple cavitatory lesions will be there within the lung, and that is what is called as the Kaplan syndrome. Okay, so rheumatoid arthritis plus 𝐒𝐻𝐼𝐴 pneumoconiosis is nothing but your Kaplan syndrome. Then coming to the vaginous granulomatosis. Vaginous granulomatosis, it is a form of small vessel vasculitis, and in patients with the vaginous granulomatosis, which is a small vessel vasculitis, you have a triad of manifestations. You have upper respiratory tract involvement, you have lower respiratory tract involvement, and you have the involvement of the kidney. And in the as a part of your lower respiratory tract involvement, in case of vaginous, you have the cavity formation. Alright, and you take squamous cell carcinoma. Both of these, squamous cell carcinoma and as well as the small cell carcinoma, in both of them, you have the cavity formation. Right, you have the cavity formation. So the place where you don't have the cavity formation is in cases of the hamartoma. Okay, so these are some of the very important multiple choice questions on the topic of bronchogenic carcinoma. Thank you very much.